Hey guys, Joel here with the Shift Brief. Today we're going to be discussing sepsis, talking about some of the pathophysiology behind it, and discussing oxygenation and how it applies to sepsis. So let's get going. So to get started, we have to ask ourselves what exactly is sepsis and how does it affect our body? Sepsis can be easily defined as the body's extreme reaction to infection. Infections can be things like urinary tract infections, pneumonias, appendicitis, cellulitis, and the list goes on and on. It has widespread effects on all organs, and it can be fatal if it's not treated properly. So what exactly happens during sepsis? Well, infection causes a massive inflammatory response by the body. Mediators such as white blood cells, histamine, cytokines, these things cause vasodilation, they increase vascular permeability. What you get is fluid shifting from the inside of the vessels to the outside of the tissues, causing relative hypovolemia. As vascular permeability increases, blood flow will become impaired at the capillary level. The body will attempt to maintain homeostasis by increasing heart rate, respiratory rate, and other various compensatory mechanisms. As those mechanisms fail, organ dysfunction and cellular hypoxia occur. When considering sepsis, first we need to evaluate for SIRS criteria, or Systemic Inflammatory Response Syndrome. In the pre-hospital setting, we have to do a modified version of this because we're unable to test for an elevated white blood cell count. What we're looking for is for any two of the following: a heart rate over 90, respiratory rate over 20, or end-tidal CO2 less than 32, a temp over 38 or less than 36 degrees Celsius. Once we've established that SIRS criteria is present, we need to look for a source of suspected infection. If we find a source of infection, that plus SIRS criteria is enough to call this sepsis. If we have sepsis and signs of hypoperfusion, so delayed cap refill, altered level of consciousness, we can then call that severe sepsis. To escalate one step further, if we have severe sepsis plus hypotension, then we call that septic shock. So now that we better understand what sepsis is, we can ask ourselves, why is giving supplemental oxygen so important? Ladies and gentlemen, I give to you the oxyhemoglobin dissociation curve. To put it as simply as possible, the oxyhemoglobin dissociation curve describes the relationship between the partial pressure of oxygen, that's the oxygen dissolved in plasma, to the oxyhemoglobin saturation, so the amount of oxygen or the percentage of oxygen that is bound to the hemoglobin in the blood. There are four factors that influence the oxyhemoglobin dissociation curve and whether it gets a left shift or a right shift. For the purpose of this episode, we're going to talk about just the right shift on the curve. So pH being a measure of the acidity or alkalinity of your blood, normal values being 7.35 to 7.45. CO2 is a waste product of cellular metabolism, and normal values being 35 to 45 millimeters of mercury. 2,3-DPG is a molecule inside red blood cells that regulates how hemoglobin carries oxygen. And then of course there's temperature, and that's just talking about your body's core temperature, with a normal range being 36 to 38 degrees Celsius. So now let's put it all together. A right shift on the oxyhemoglobin dissociation curve means that hemoglobin has less affinity for oxygen and unloads it more readily. It just wants to get rid of it. Although it unloads faster, tissue hypoxia still occurs as a result of capillary leakage and impaired microcirculatory blood flow. You can see this in a previous episode that I did covering microcirculation. Sepsis will cause a decrease in your pH, an increase in your temperature, occasionally a decrease, but more often an increase in temperature. It increases 2,3-DPG and increases CO2 from poorly perfused tissues, as in they have a decreased ability to remove the waste. All this stuff added together causes a right shift on the oxyhemoglobin dissociation curve. With a lesser affinity for oxygen, a slightly higher PO2 is required to cause the same percentage of oxygen-bound hemoglobin. When we administer oxygen, this increases the amount of oxygen that is actually dissolved in the blood plasma, or the PO2, and it makes it more readily available to bind with hemoglobin. Since the hemoglobin has less affinity for oxygen, It is empty more often, and we want to be able to fill it right back up with oxygen. That helps combat tissue hypoxia, cellular death, and organ dysfunction. So what exactly is our SpO2 goal? Well, that SpO2 goal has to be 94 to 99%. We know that hyperoxia is associated with increased mortality, and we're no longer shooting for 100%. Guys, thanks for tuning in and watching. Sepsis has a very complicated pathophysiology, and this episode was really just talking about oxygenation and its importance in sepsis. When it comes to actually treating sepsis, there's lots to consider, antibiotics, vasopressors, fluid resuscitation, things like that. Make sure that you like, comment, and subscribe to my channel, and stay tuned for more pre-hospital paramedic-based content.